Okay. Good morning, dear faculty, and also dear participant PG students. A very nice day. We have come to the last day of our workshop, and I have interacted with some of you over the last 4 or 5 days, and I could get that you are able to enjoy and understand what is being taught. So the agenda for today is we would look at the study that we wanted to design. There is a hypothesis here. What is the hypothesis? Any study, before it is undertaken, it will be in the form of a hypothesis, or you can say a program or a plan, something like a route map. You would try to create, and using that protocol, which is the route map, you try to work on the hypothesis. Hypothesis is an untested question. Once it is tested, it becomes a study. What is the hypothesis here? Giving Horlicks to children will increase their weight. As simple as that. If you give a nutritional supplement to the children, theoretically, biologically, there is a connection that it should probably improve their height. So this hypothesis is to be tested, for which we are here to design a study. We are not conducting the study as yet. We are just designing the study. And even if we go into the serious design of it, we wanted to prepare a protocol. A protocol is a pre-agreed document agreed by all the investigators and also the participants that we will go according to this plan or pre-planned route. Suppose you want to travel from Vizag to Bangalore. So you will plan a route either by air or road or train, and as per that route you go. And if you don't miss the route, you will reach certainly the end. If you don't follow and keep on driving in a way you want here and there, you may be circling around Vizag and never come to Bangalore. Okay, so that is the idea of trying to generate a protocol. Here, just now Dr. Sameena madam has circulated to me that the following PGs have evinced interest and are participating in generating this proposal. I wholeheartedly congratulate them for showing the interest, and some of them have talked to me also. The other PGs who have not participated, I am very sure they are in the back of the discussions between their colleagues, and it is to acknowledge that every one of us is doing this. That is why you would see I haven't put any name on the hypothesis slide. I didn't put Dr. Sarma or anyone PG or anything. So the research question is developed by Dr. Deepa from Medicine Department, comparison group and study design by Surgical PG Monisha, and then inclusion criteria by Pediatrics PG Dr. Naveen, and exclusion criteria from Ortho Department Dr. Ravi Teja, baseline measurements from Radiology Department Dr. Gautam, and then follow-up by Anesthesia PG Dr. Sameena, outcome measurements by OBG PG Meghana, and standardization of the measurements SPM Priyadarshini. I haven't seen her nor got anything from her. Dependent and independent variables Monica. Proforma from the ENT department Nirisha, I don't know, Nitisha, whatever it is. Please correct me if I am wrong. Data presentation from ophthalmology by Ramya, statistical analysis from pharmacology by Dr. Vijay, and p-value and statistical analysis, and then delta and all from DVL department, Dr. I think DVL is diploma in venereology and leprosy, I think. Dermatology, venereology and leprosy, Ashifa, and reporting from pulmonology, Dr. Lavanya. These are the people who have shown interest to participate. Why I am reading the names? You feel very happy if your name is included in doing anything. Particularly as a youngster, you would like to see your name somewhere in the publication or in the paper or in the presentation or something like that. I used to enjoy that. But at this stage, I don't really bother whether my name is there or not there or anything. Nonetheless, it is important to give the name, to give the responsibility to the person who is actually assigned to do or who has published it. Suppose I put the name on the title slide, for that presentation, I am responsible for all the follies as well as for the good things also in that presentation. That is the idea. So once again, congratulate all of us. We congratulate ourselves for completing the 5 days of the workshop. And we are here that we are going to discuss about the hypothesis. The first and fundamental thing about the hypothesis is you must have a blueprint. So this is done by whom? There is already a title there. GEMS first year PG group is developing it, not one individual. Okay, GEMS first year PG group has evinced interest to develop a proposal. And for that proposal, first of all, you must write what is called the side headings you call. When you want to write something, you will write the side headings. So the side headings here are question, comparison group, study design, inclusion and exclusion criteria, baseline measurements, follow-up measurements, outcomes that we wanted to use. Outcomes are the measurable things at the end of the study, Proforma, data recording, clinical and statistical significance, and finally analysis and reporting. So what is missing in this list is sample size. So which we will do it. We have not asked you to do it because you are not very thorough with that. So we'll try and do that sample size also. Okay. Now let us start with one by one. So what did I do? Whenever you have to develop a proposal, you must have the habit of developing the side headings first. And that is what is called your tentative blueprint. You can always alter. Once you start doing, you get a new ideas. You can change the order, or you can add or delete or combine certain areas which you wanted to discuss. But nonetheless, it is important for you or for anyone for that matter to write a probable list of things which you would include in the protocol. Okay, something like your things to do to finish the protocol. Okay, that's what we have given here. And the first and fundamental thing is the research question. So we have to very clearly state our research question without any double understanding or ambiguity or inconsistency or inability to properly explain or explicit. So this should be written in a very explicit language. And the keywords should be underlined. What are the keywords? We are using Horlicks as an intervention. What are we going to measure? Change in the height. How long is the follow-up? 1 year. Whom we are trying? Not 60-year-old person or 80-year-old grandmother. We are trying in children 3 to 12 years. So what I did? I highlighted those 4 areas. Horlicks, can it give gain in weight if given over a period of 1 year for children of 3 to 12 years? That directly looking at the 4 phrases or words, one will be able to see, yeah, what is the interest there. But you have to put a very clear-cut question also. The question is, does nutritional supplementation? Why did I say nutritional? Because it is not a therapeutic intervention, not a drug or any intervention we are giving to treat. So it is a nutritional supplementation with Horlicks. If you want to research on Complan or if you want to research on Protein X, you can do the same proposal. Substitute Horlicks with the other beverage or any other nutritional supplements. You want to give, let us say, groundnut and jaggery powder together and made into balls. And every child takes 3 balls or 4 balls per day. That is a very good protein supplementation. We know that groundnut, Bengal gram, and then jaggery together are powdered and made into round, very eatable balls. Children love it. And that could also be an intervention. But for our question, we have used Horlicks, so we did. Horlicks being a beverage, given what is the frequency we have to say, not once in a week, we have to give twice a day. At least twice a day, over a period of how long? At least 1 year for the height to show some improvement. 1 year may be an important landmark. I don't know. Maybe we may require 2 years also. But for the moment, we will call it as 1 year study. If necessary, we'll have a provision to extend it. Supposing the difference is there, but it is not very clear, then probably we increase the duration for 2 years or 1.5 years and see. So where are we studying? In children, in the age group of 3 to 12 years. So that is as clear as that question. So always cultivate the habit of writing a very clear, sir, I wanted to study liver. What is that? Sir, I wanted to study the effect of fatty food on in diabetes. No, that is not a question. That can be a hypothesis. That can be a hypothesis, but you have to develop a research question. Cultivate the habit of developing a good research question. A good research question goes a long way in developing it into a protocol. Now, whom are the what is the study design like? Nobody has written a study design slide. I would write a study design slide also, and that study design includes this is a prospective study. So we have to say that this is a prospective study, and the prospective study for 1 year, either we randomly generate 3 groups, or we have to generate as and when they occur, the children will be coming, and you put them into one or the other group, non-randomly also. Here a little bit of discussion is required. So can whichever child is coming to my OP, can I randomly allocate to treatment A, which is Horlicks, treatment B, which is milk, and treatment C, that is, intervention C, which is nothing. We don't give anything, and they will be taking all that. It is rather tough. Why it is tough to randomize children for a nutritional beverage is, if you want to supplement nutritional beverage, there will be children who are in the same family who would be also be given the nutrition supplement. We can't ask the mother only to restrict Horlicks to the child whom you have selected randomly to get Horlicks, and if the other child gets, no intervention, it's not possible. Mother is not going to agree, and child also is not going to agree. So how do you go about? So what I'm saying is, imagine that there are 3 children in a family. One you randomized by your randomization process, you got Horlicks. The other one you got milk. The other one has got nothing. Is it possible for the mother to discriminate like that? Will the child be happy with that? You cannot. It's okay once, but you want to do it for 1 year. It's not possible. So what you have to do? You have to do cluster randomization. What is cluster randomization? Take household as a cluster. Okay. So one household, whatever children are there selected in that thing with the exclusion criteria, if they are healthy, all of them have to get one intervention. You can say why the excluded children are getting. We can say the child has a disease. Probably this is not good for the child to give, so we can convince. So we do a cluster randomization, taking household as the cluster. Or you can do still better, still easier would be take around 12 villages in and around Srikakulam. So randomly allocate the 12 villages to the 3 interventions. Similar size villages, similar socioeconomic status, 4 villages for each group into 3. And 1 village is Horlicks group, 1 village is milk group, 1 village is no intervention. That is much easier practically, because it is easy to convince the mother from the neighboring household. No, why are you giving Horlicks to that household? Why are you not giving to my children? They start quarreling. So very difficult. So better still, village-wise cluster randomization may be better. So if you want, you can increase the villages to 12 or say 14 or whatever is the number. Divide them into 3 groups, whatever is the group. So randomization at an individual level is not very correct for these reasons. Second thing is, if I randomize a child and put him in one of the treatment groups, how do I get back the child for follow-up? One child may be in one corner of the village, another child will be 20 kilometers away in another village. I can't run hither and thither. Instead, I select the villages. It's easy. I have to go only to the selected 9 or 12 villages and then go and measure them at the time intervals. And these do not require their hospital attendance like a CT scan or MRI or X-ray. So they don't require to be brought to the hospital. We can as well go to the doorstep and measure. That way the compliance for measurement will be much better. The dropouts will be much less. So think about these things, the practicality of randomization. So when we are randomizing, so we have to stratify the children. So stratification means we know age is an important variable. So we will divide the children into 3, 4, 5, one group, 6, 7, 8 in another group, 9 and 10, one group, 11 and 12, another group. First two age groups, 3 and 3, second two age groups, 2 and 2, like that, make them into 4 groups. See that children of each of these age groups are included in your study. So when you are randomizing at individual level, you can do age-wise randomization. When you are doing household-wise, whatever children are there in the household, you randomize. When you are taking villages, the randomization, then all the children, eligible children in that village are randomized to that intervention. So that way you remember. What is the area we wanted to take? In and around Srikakulam district, Srikakulam village or town, neighboring areas, neighboring villages of Srikakulam. And better not enter the urban environment for a study like this, because the behavior of urban environment people and their affordabilities are very different compared to people who are in the rural areas. For a nutritional supplement, probably better include study population only from the rural background of Srikakulam district. Age group, we said any child in that family or in that village 3 to 12 years will be included. Older children we are not including because they form the adult group after 12 years. Their growth spurt is different, their maturation occurs, and the growth in which the way in which they grow varies depending upon the biology and the endocrine function. And also we restrict up to 12 years would be ideal. And the earliest would be 3 years, because 2 year, 1 year child, difficult to make compliance a possible thing. So instead of saying hospital-based, I would probably say this will be a community-based study. A community-based study based on village as the randomizing unit or the household as the randomizing unit. And then the age group of 3 to 12 years we will take. We said healthy within quotes. What is healthy? Very difficult to define. Absence of disease. So we have to do certain tests to eliminate chronic diseases versus somebody who has got acute fever for 3 days and recovered. Somebody has fallen and had an injury and recovered. Somebody has got a small abscess on the hand and they recovered. So they are all healthy only for practical purposes for our particular study. So we would like to exclude those people who are chronically ill, which can have a bearing on the weight and height. So what is the study period? Recruitment period is around 1 year. So 1st January we start. Not all children are recruited in 1 year. We start within 1 month or so, we complete the recruitment. And the follow-up will be 6 months and 12 months from the day of recruitment. So that will be the inclusion criteria. Children with chronic illnesses will be excluded. Now we'll see what are the exclusion criteria. Why these are important? This is make you understand not the content of the nutritional study, but the methodology of doing a nutritional study. You must have the exclusion criteria. Certain people will not be eligible for in the study to be in the study because they have disease which is a confounding effect. We told earlier what is a confounder. A confounding effect on the outcome or on the intervention we are making. Nutritional deficiencies, kwashiorkor, marasmus or marasmus, systemic illnesses like chronic diarrhea, malabsorptions, lactose intolerance also you can put there. In such a case, you cannot give milk and you can add lactose intolerance. Please note the points and update that slide, whoever is doing the exclusion criteria. And somebody who is given the study design, the slide is not prepared, depending on what I discussed, you write about the cluster randomization, village-wise or household-wise and how we do that, you write and prepare that. Okay, now malabsorptions, chronic diarrhea, lactose intolerance, congenital heart diseases, cerebral palsy, chronic renal failure, worm infestations, and very, very important in our country. Worm infestation is so common. You may not have cerebral palsy, many children, nor you may have chronic renal failure also, not many in the community. But worm infestations are very common, then that could interfere with this one. One way of doing it is you find out whether they are worm infested and treat, or give them deworming to all the 3 groups, a starting dose of deworming and 6 months also one more dose of mebendazole or gentle or whatever it is you give, so that the worm infestations will not play a part. This is a single time intervention. Just give one tablet or one syrup bottle and ask the child to swallow under your supervision. And every study child in all the three groups gets it. And it is a good thing for the child to be dewormed in the village, isn't it? So that is how we need to tackle the worm infestations, endocrine disorders. Certainly, if the child is having growth hormone or thyroid, hypo or hyper Cushing's, they will have a bearing on the weight and height. So we want to exclude them. Genetic conditions, Downs, Turner, Klinefelter, achondroplasia, so many names our doctor has written here. That's so rare. So in a community study where we take around 10, 12 villages, hardly there are one or two children who have those things. But if you find some child like that, you exclude. Okay. And most important thing, the common things first, nutritional deficiencies can be common, worm infestations can be common, diarrhea could be a problem, lactose intolerance can be a problem. So those are the common important ones. Other rarer things, of course, if your child is having a specific chronic disease which interferes with our study measurement, the weight and height, of course, we will exclude them. So we have completed research question, study design, inclusion criteria, exclusion criteria. Okay. So variable under the study. What are the variables? There are two types of variables will be there. One is called the primary variable. The other is called the primary independent variable and then the dependent variable. So height and weight are the primary independent variables. And the dependent variables are you are giving Horlicks, milk, normal diet in the control group, and other important variables which can have which we need to measure are the socioeconomic status, educational level of the parents, age of the child, gender of the child, number of siblings, all can have an effect on the outcome. So we won't do anything for them, but record them and try and see whether all the three groups are comparable in terms of socioeconomic status, in terms of educational level, in terms of of course, age we are using as a parameter to put them in the groups, gender of the child, and also the number of siblings. So we require to know, we have to very clearly identify what are our variables. The outcome variable, also called the independent variable, you can better word it as outcome variable. It becomes easier for you to remember what is called experimental variable and outcome variable. If you use these two words, there is no confusion which is primary and which is secondary. Use the outcome variable here is height and weight. That is the outcome you are going to measure. The experiment is Horlicks, milk, and no, nothing. So this is the experimental variable. Other non-experimental variables which can come into picture are those which are listed here. Okay. You can also measure skin fold thickness as a part of height and weight. In fact, it has written, but I removed it because it's good to have one or two variables as the primary outcome variables, not many. You can have a number of secondary outcome variables also. So the lady has given an extensive proforma for this, and of course, the first part, it contains several parts. The first part is the patient ID details, name, registration number, and then address. Name should include both the first name and the second name. Second name is the family name or a father name, depending on what is the practice there. And then registration number, some study number you have to give. So it's easy to identify the reports with each study number. The address, of course, the name and contact details of parent or guardian, the address of the parent same as the child, probably child will not have a separate address. So you can have one address column where the address of the guardian is recorded. Consent from the guardian, of course, is you can take this consent in a separate form, and it is not part of the proforma, but then consent is essential for any study. Here the consent is very straightforward because we are not going to do anything untoward or any risky thing. Only thing is that to make the parents comply with what we are asking them to do is a little difficult task. So just imagine you wanted to give Horlicks to some group of children, A group, B group only milk, and C group nothing. How do you ensure that the child daily drinks Horlicks morning and evening? How do you ensure? Will you go to each doorstep and catch hold of the child. In a flask, you carry Horlicks, put it in the mouth of the child. Ideal, but not practical, isn't it? So we have to ask the mother to give. We have to give them supply of Horlicks. Per day you are asking 30 grams. 30 days is 900 grams. So 1 kilogram of Horlicks bottle you give per child. If the 3 children are involved in that particular household, 3 kilogram jars, 3 have. And we have to educate the mother or whoever is the caregiver to mix it properly and give it to the child at the right time every day. What will be the compliance? How many mothers will comply with your request? They may forget. They may go to the relative's place for a wedding or any other function. They may stay there for 1 month and don't return. They forget to take the Horlicks bottle with them. What do you do with them? Think over. This is whenever you do research, ideality is very easy. Easy to say, yes, group A I give Horlicks, group B no Horlicks. But practically in the doorstep and in the practicality, in the real life, it is difficult to enforce the intervention. Unless it is an injection or a tablet once to be given and you call them to the hospital, just give the shot or give the tablets for a week or so, can expect them to take. Over a period of 1 year, the investigator expects the mother to give faithfully Horlicks twice a day. What interest the woman has got to find an answer for this question? So you have to generate that interest, and there must be a diary where they will record, yes, given like that. There will be a health worker going and visiting them once in 3 days or once in a week to the households and cross-checking with them and reminding them that they have to give this and follow the same intervention without anything. If there are any issues like diarrhea or indigestion with the Horlicks, they may stop it. Then we must ask them to report and then correct them or reintroduce after a period of 3 or 4 days and note the period of absence also. All these are practicalities. Okay, so the patient ID details we have covered, epidemiological data, age and date of birth, gender, education of the child, parents' educational status, socioeconomic status, all will be recorded. The third part of the Proforma is clinical history of any other illness, diarrhea, vomiting, congenital diseases, high thyroid, other diseases, and nutritional intake, particularly vegetarian, non-vegetarian, or mixed diet. Mostly vegetarian or mixed is adequate because non-vegetarians do take a mixed diet only. Any other midday meal program the child is in, that is important for us because if they're receiving other nutritional supplements, let us say if one group of our children are receiving and the other group is not receiving, that could be the reason and not your Horlicks. So if they are in that, we have to record and what they are taking. That also to be entered. Clinical history, what is the birth weight, what are the milestones like, and the birth order of the child is how is the appetite of the child, bowel and bladder, sleeping. I don't know whether what way sleep will be interfering with our study. Maybe yes, maybe no. Family history of any chronic illness is important. Parents' height could have a bearing on the height group. So this is about Proforma and clinical history and patient's measurements and clinical examination. She has written height, weight, and probably BMI you calculate, skin fold thickness, vitals like pulse, BP, respiratory temperature. Why these things are required? If you are going to analyze them, you analyze. This is only to exclude disease, people who have disease. Otherwise, I am not interested to know what is the blood pressure or respiratory rate of the child. At the baseline, I examine them and just they will be useful for exclusion criteria. I don't put them in the Proforma because each time committing myself to do respiratory rate on every child, when that has got no bearing on my nutrition, I don't think we should do it. Okay, just as a baseline you measure, because every person we examine, we require to know the vitals, particularly those who have heart diseases and all can be excluded for that baseline, okay, not for follow-up. Investigations to exclude chronic illness like liver function, kidney function, and ECG and X-ray chest. And what are all the routine things you do to exclude those? So many diseases we said we wanted to exclude. And for the study purpose, we can measure serum proteins, which might have a bearing in the growth, and also anemia, hemoglobin, and PCV could be study investigations apart from height, weight, and BMI. Now, this lady has given a beautiful table about the data representation. You look here, you can easily see there are three big groups: Group A, Group B, and Group C. Group A is the active intervention Horlicks and milk. Group B only milk, and this milk also in both the cases you standardize, saying they will get 150 ml of 2% milk or whatever it is. So not that one group gets fat removed skimmed milk, the other group gets a full whole milk. So being children, they can be given whole milk instead of skimmed milk. So same thing will be used. And group C, we will just naturally ask the mother to do whatever she is doing. So this is the group A, B, and C, and our main outcome variables are height and weight. Okay, and age groups are 3, 4, 5, 6, 7, 8, 9, and 10, and 11 and 12. So you put them on this side, and each age group you get some number of children, and you write the number there. And for the height and weight, you write the mean height, mean weight, and then the standard deviation of the height and standard deviation. For an individual child, there won't be any standard deviation. There will be and mean, just the height and weight you record. When you summarize them, then of course it will be useful. All children of 3 to 5 will be summarized in this fashion using the number, mean, and the SD. For an individual child, if you want to record in the Proforma, the same thing can be used. But this is an analysis or data presentation. So we are not using one child here. We are using 3 to 5. Let's say 50 children are there. That number we write as 50. What is the mean value? What is the standard deviation of the height and weight? Likewise for all the age groups, and likewise for group B and group C. So what is our interest? Our interest is to see the delta. What is delta? Mu1 minus mu2 and or mu1 minus mu3. Okay, all possibles. Just the intervention is mu1 and the control is B and C are two other groups. So mu1 minus mu2 and mu1 minus mu3, two deltas will be generated. Okay, so the mu1 and mu2 are generated there. The delta difference from the mu's are generated. They will be used. So this table will be filled for 0 day, that is when they are enrolled, and at the end of 6 months and at the end of 12 months. An additional delta table has to be prepared between that will have a delta 1 and delta 2. Delta 1 being A minus B, delta 2 will be A minus C. Okay. So this is the data representation, very correct, nicely. So the question of p-value. So all of you should understand what is p-value, what is the strength of association. Alpha error traditionally 5%, 0.05. Test of significance is done by repeat ANOVA. Why did we do repeat? What are the groups we are having? We have to be very clear about the test of significance. What are the groups we are having here? What is the type of variable? Is it ordinal variable, nominal variable, or a measurement in terms of number? It is a discrete variable. It is a quantitative variable. So when quantitative variable, no chi-square, no z-square, nothing, we have to do either a paired or unpaired t-test or ANOVA or something. Okay. Are there repeat measurements or are there independent measurements? There are repeat measurements because we are measuring children before 6 months and 12 months. So we are taking repeat measurements before the intervention, 6 months after the intervention, 12 months. So this is a sort of quantitative data, repeat measurements, and multiple groups, not two groups. If two groups, we could have used a paired t-test, but it is not two groups. What are the three? More than two groups? Horlicks group, milk group, and control group. So we have three groups, and we have a number as the measurement, and this is a sort of quantitative data, and it is a paired observation. And of course, we have to demonstrate that the distribution is normal. How do I demonstrate? I plot all the values of weight and height of different groups A, B, C, and see that the standard deviation is less than half of the mean. Okay, that is a parametric distribution or normal distribution. So 4 conditions should be satisfied before we do a parametric test. 1, the distribution should be parametric as evidenced by standard deviation less than 50% of the mean. 2, there are multiple groups. And 3, it is a paired observation because we are taking repeat measurements. And 4, it is a quantitative variable. For such a thing, the test of significance will be repeat sample ANOVA. That you have to do. Also, there are certain proportions in the study, like proportion of children in different age groups, percentages. Those can be compared across the groups using a chi-square. The primary analysis is repeat sample ANOVA. The subgroup comparisons of proportions of children, proportion with socioeconomic status, proportion with different educational levels, proportion of children who are males and females, all those comparisons you can compare using a chi-square. So what is the H naught here? Hypothesis, null hypothesis. It is called the mean gain in weight in all the groups is same. That is the hypothesis which we started. But that is not what we have written in the beginning. That is a study hypothesis. Null hypothesis is we assume when you start a statistical test that mu1 is my delta mu1 is equal to delta mu2 is equal to delta mu3. Okay, delta is the difference between the first and the final. Okay, first measurement and the final measurement, you call that as delta, and they take all the delta values, so take a mean value, average value, and calculate a standard deviation also for that. Mean and standard deviations will be available, and you will get for group A and group B and group C, we call them as mu1, mu2, and mu3, and all are equal. This is our null hypothesis. But when we do an investigation, we are not interested to confirm the null hypothesis. We wanted to refute the null hypothesis or drop the null hypothesis or reject the null hypothesis. In order to do that, we must have enough error-free observations. That error, we are keeping it as 5% and we work out a p-value. If the p-value is less than 0.05 by our statistical test, the significant result is there. That means we reject the null hypothesis and accept the alternate hypothesis. Study becomes significant and you conclude that Horlicks works or Horlicks increases the height. The other way around, you may end up with p-value more than 0.05. Then the value is not statistically significant. Then we accept that there is no difference between mu1 and delta mu1, mu2, and mu3 and accept the null hypothesis. And we cannot draw any conclusion of difference because of Horlicks. And we can only say our study, Horlicks did not demonstrate any gain in height. Okay, that should be as clear as you in your mind. Null hypothesis is the hypothesis you start off when you really are beginning the investigation in the statistical evaluation. And then that says that mu1, mu2, mu3 are same. Our idea is to confirm or refute it. And how do I do that? By ending the study calculations of test of significance by repeat sample ANOVA, I get a p-value. Supposing the p-value is less than 0.05, I am very confident my error in rejecting the null hypothesis and accepting the hypothesis of difference is less than 5%. The alpha error I set up at 5, but I have come below that and I am happy. And I conclude that Horlicks does increase the height in the study. The other way around, my study ends up in a p-value which is greater than 0.05. Oh, I can't reject the null hypothesis. I have to say that there is no difference. If I by chance I want to conclude like that, my error is so much. This is not by chance. 5% can be the chance. More than that it is, there is no difference. That is why we are not finding it. And we will not be able to reject the null hypothesis. We continue to be in the null hypothesis and continue to say that there is no difference between group A, group B, and C, and all the mu1, mu2, mu3 are not different from one another. This has to go into your mind. That is why all this exercise. Okay, strength of association, p-value means this one. So if you see a study in any literature you read, if the p-value is less than 0.05, the investigators are justified in concluding that the null hypothesis is not correct and take up whatever is the alternate hypothesis. But before that, you must have a clinical significance. That means the weight gain that you get due to Horlicks should not be so trivial. It must be substantial, at least 20 or 30% of the other groups. Then you would be clinically interested to accept it. Without clinical significance, statistical significance is meaningless. Without statistical significance, clinical significance alone, if it is reached, you will not be able to conclude and reject the null hypothesis. So it goes without saying, clinical significance is fundamental, statistical significance is vital to conclude the difference is there and accept the answer. How do I follow it up? The follow-up is for 1 year. There are 3 groups as we have already discussed. Measurement of height and weight will be done. And we have to here say that we have to very clearly say how do we measure the height, how do you measure the weight, up to what decimal you will measure the weight, and what scale you use, how do you standardize that, how do you avoid instrument variation, how do you avoid observer variation. Particularly if you want to go and measure in the village, all the more you must have the gadget with you, standard one, a digital scale, and probably a height stand also. Probably a child should be made to stand, and then the top should be aligning with the top part of that height scale, and then you just measure correctly the reading. So all those things have to be done, and weight probably you just take 2 readings and then take an average of that or whatever. Okay, so that is about standardization, the measurement of height and weight. When do I do? 0, 6 months, and 12 months. Okay, the mean difference is generated between the 3 groups, particularly between 1 and 3 and 1 and 2. 1 and 2 we call it as delta 1, and 1 and 3 we call it as delta 2. And we may not be really interested to look at the difference between 2 and 3. Because if there is a difference between 1 and 3, that is adequate, because these people also are getting milk. So the analysis is done by test. For repeated ANOVA, test will be done using repeated ANOVA. Why repeated ANOVA? 1, the variable is quantitative. 2, there are more than 3 groups. And 3, there is a paired measurement or same individual is measured 3 times. And 4, of course, it is parametrically distributed or normally distributed, which we will demonstrate with the data in hand, demonstrate that the standard deviation is less than 50% of the mean. So reporting the study. So that is important. To write a report, we have to say that we have examined like this, what we have done. We will write about the methods briefly, and then also the measurements we write. We specify our outcome variables, the primary sort of outcome variable and secondary outcome variable, and primary experimental variable and primary intervention or experimental variables also. We will write and then say the data given as per the table, and we say what test we did and what is by melt by null hypothesis, what is our p-value, and also what is the p-value, and also the null hypothesis, when it is rejected, when it is accepted, all have to be done. So with that, the reporting is over. And then what else we have to do is we have to do the sample size calculation. And when you do the discussion, what you will be doing will be, you will be comparing with any similar other studies. Supposing there is any other study with Horlicks, it is wonderful to compare. Suppose they don't have with Horlicks, they have with Complan or some other protein drink or some other nutrition supplement. Then they are nearer to your study and you can compare and do that. Okay. So this is all about, and how do I go about sample size? I will show you in a moment's time how to do that. So let me enter this website. The other day I haven't shown you. I'll enter that website and I will share that for you. So we are interested in what? Proportion or mean? We are interested in the mean only, isn't it? So we must take the calculator for comparing the two means. What is the sample size? So it is asking me to give the difference. What is the confidence level you need? Typically 95%. Isn't it? Confidence level is the alpha error. I don't want to make a wrong conclusion and I accept an error in my conclusion of rejecting the null hypothesis, 5% error. When I reject the null hypothesis and accept the alternate hypothesis, my type 1 error should be 5 or less than 5%. Or I must be 95% confident that my conclusion is correct. That one can vary also to 95 and 99, but let us say we keep it for 95. The power of the study we would like to use, that is the beta error is 20%. So power is 1 minus beta error. This is the when we not reject the null hypothesis. We accept the null hypothesis. What is the error we are committing? If there is a real difference, the error of missing that real difference is the beta error, that is 20%. Alpha error is when you reject the null hypothesis, you commit that error. Beta error is when you accept the null hypothesis, you commit the beta error. Accepting is omission and rejecting is error of commission. So type 1 error is alpha error, type 2 error is beta error. So 20% is normally the allowed beta error when you fail to reject the null hypothesis, or in other words, accept that there is no difference. And such a scenario, the power of the study is called 80%. 1 minus 0.2 is equal to 0.8, which is 80%. What is the hypothesized difference? What difference you expect between the delta A they are asking? Is it 10 centimeters difference will be there with Horlicks and no Horlicks? 10 centimeters is a huge difference in one year, isn't it? We don't expect that much. So let us keep that as the growth itself may be 5 centimeters. 50% of that will be around 2.5 centimeters. If there is a 50% difference, I would require, see there, 2,512 children is the sample size. And this is for the N, that is one arm. How many arms we have? 3 arms. So 7,500 children we require. 2,500 into 3 is 7,500 children, and they will be distributed, if you say around 20% of the population, they will be in around 20 villages. Probably you have to visit to get that. Supposing we make this instead of 2.5, we will make 4 centimeters as the difference. Then around 1,000 subjects are adequate. You see the red part there. So depending on the delta you change, and or if you know that the variance in your population is not much and your children are uniform, then we can reduce the variance there. We can reduce the variance to 100. Automatically the sample size comes down. If the variance is less, then it's easy to detect a difference. If the variation is more, it's difficult to detect. See, 500 is to 5,000, 1,000 is probably a little higher. I keep the variance around 400. So, and 2.5 is the difference. Maybe around 1,000 children per arm. 3,000 children would be the sample size. Now you understand what are the things that are going into sample size calculation? What is your alpha error? That is here. Supposing I want to make it 99% sure, then I have to increase the sample size. Instead, I say, okay, I'm happy with 10% error and I'll keep 90. Marginally, the number is reduced, but it's not acceptable. Statistically, always you have to keep 95. Very rarely we go in for 90%. When you are thinking of equality between the interventions, you can keep it at 90% or 80% also. Then I won't reject at all, and instead I will increase my power. When I'm thinking that 2 interventions are same, I want to demonstrate that both are same, then the power should be more and not the alpha error. Then the beta error should be 95. Okay, so you understand, depending on the question, you either adjust the alpha error or beta error. Conventionally, alpha error 95, beta error 20. So 1 minus beta power is 80. And the hypothesis difference is 2.5 centimeters more growth in the intervention group compared to any one of the 2 groups. That is what we hypothesize. If that is not there, I may be not interested clinically to take up any difference of 1 centimeter or 2 centimeters difference. So, but expecting 5 centimeter difference is too much, because that much amount of growth in 1 year may not be there. So population variance, this you can get from literature. What is the variance in the height and weight, particularly the height, and that number you have to put. I assumed it as 400 and got a sample size of 1,000 children in each group, saying that I require 3,000 children in the community study to complete the hypothesis testing and test my thing. So you understand now, 1, the confidence, that is the alpha error; 2, the beta error; 3, the delta, that is mu1 minus mu2; and 4, the population variance. And these are very much required. The more number of stratifications you have, the more will be your sample size. Supposing you want, if you stratify, what you will be doing is, you would like to make subgroup conclusions that this age group is better than that age group, this gender is better or worse than that gender. If you want to do all those things, you require to study more subjects. This is to tell you that research is not studying 5 subjects and writing something, or studying some 25 people, some sort of descriptive study and writing like that. You require for a simple test study like this, you require 1,000 into 3, 3,000 people are required to study. To enroll them, I don't know how many months it will take in a GEMS hospital, but better in such a scenario, you go to the community and enroll more children faster. So better to be a community-oriented study. I'm stopping it. So we have done everything. Let me just go ahead and project that particular slide, first slide. So this is a question we have discussed. Here, the issue of finer I wanted to talk to you. So what is this finer? This finer is the feasible. Yes, feasible. But remember, when you say feasible, can you enforce the intervention properly, that every child gets the Horlicks as you thought? It's a little difficult. Conceptually, it is easy. Practically, it is difficult. Interesting, certainly interesting to know. Novel, nothing very novel, but okay, you can try and see. There may not be many studies to show. Ethical, no doubt about it. And then, of course, it is representing our population. So the question is the feasibility only. I have a little bit suspicion. Comparison group, we discussed the 3 groups there, and then the study design, either an RCT or a cluster randomization based as a village as the randomization, or the household as the randomization. With age stratification if it is individual, otherwise if it is village or cluster, we cannot age stratify it. We can only stratify based on the households. And inclusion criteria, healthy children, when I said, we exclude chronic conditions. Age group, we said. Exclusion, we have already discussed all the exclusion. Baseline measurements, we have discussed. Follow-up, we discussed. Outcomes, we discussed. Proforma parts, we have discussed. Data recording also we discussed. Clinical significance also is more than 50% of the comparison group. That's what we said. We expected 5 centimeter growth and 50%, that is 2.5. And statistical tests also we said. Analysis and reporting. Sample size is not included in this, but of course we discussed that also. Now, when you are doing this, you can as well, you're seeing this slide, all of you people can actually, those who have taken each part of it, you can further refine them in the light of what I have presented now. Most of you people have talked to me. A couple of people who have not talked to me, they can always give their views. Question gentleman has talked. Comparison groups. Study design person, I have not talked to me. Inclusion, yes. Exclusion, yes. Baseline measurements, yes. Follow-up, yes. Outcome, yes. Proforma, yes. Data recording also, yes. Clinical significance also, yes. Statistical, clinical significance I didn't give to anyone. That included under the statistical only, that way done. Analysis and reporting also. A couple of people have not responded, but doesn't matter. But you develop. Somebody has put a message saying that there is a lot of difference between inclusion criteria and exclusion criteria. Let us see what is that message.